Thanks for visiting my channel. Today is all about systemic or intravenous mannitol. If you haven't subscribed to my channel, please kindly do, because with that, you'll be able to get all my presentations immediately they are published. So, systemic or intravenous mannitol, meaning there are other forms of mannitol. It is all about systemic or intravenous mannitol. I'll make a separate presentation on other forms of mannitol. That is why subscribing to my channel will be helpful, so that when I publish that, you'll be able to get it immediately. The class. It is a sweetener and also a medication. I will not go into the differences fully today, but let me just brush over it that it's very helpful as a sweetening agent in gums, candies, in many medications, tablets or capsules, even as a sweetening agent for diabetic patients. And they use it to mask bitter taste of so many medications. So one way or the other, we have encountered mannitol. But today, it's going to be centered around the fact that it is a medication. One could be Per Oral Mannitol that will be helpful as a mucolytic agent, respiratory diagnostic agent, or for Bowel preparation for colonoscopy. I'm not going into this today. So the focus will be as the systemic medication, systemic mannitol. In that case, it is a miscellaneous diuretic, specifically osmotic diuretic agent. It's also a genito-urinary irrigant, meaning for irrigation of genito-urinary region. First of all, let's go through this note before delving deeper into intravenous mannitol. The systemic mannitol or intravenous mannitol is used more when we compare how often we use the inhalation or per oral forms of mannitol. The systemic is used more than the inhalation or per oral forms. You know, when I make some representation on inhalation or per oral mannitol, you understand why. The systemic mannitol or intravenous mannitol is all about osmotherapy. But under osmotherapy is either we go the direction of salt-based, which is hypertonic saline, or we go the direction of sugar-based osmotherapy, which will be mannitol. That is also hypertonic and hyperosmolar. The hypertonic saline or the hyperosmolar mannitol, either the salt-based or sugar-based, will be needed to draw the edema across the blood-brain barrier in cerebral edema. We have to avoid this, that is systemic mannitol, when serum osmolality is greater than 20. The reason is simple. The sugar-based osmotherapy, which is mannitol, is hyperosmolar on its own, so we don't want to add to the problem. It is not the only way to treat cerebral edema or increase intracranial pressure. Don't worry, I will go into that in a bit. Mannitol increases the cerebral blood flow, and systemic mannitol may be dangerous to the kidney. So, we must correct hypotension before we embark on its use. Uses of intravenous mannitol or systemic mannitol. Mostly, when many people hear about the word mannitol, they will think first about the brain and the osmotic diuretic effect. So we use it for the reduction of increased intracranial pressure or the treatment of cerebral edema. We use it for many other things. We'll go into that in a bit, but that is why many people will use it. However, it is not the only agent for the reduction of increased intracranial pressure or treatment of cerebral edema. And I've written down here that I will explain further. First thing first, when we are faced with increased intracranial pressure, we'll elevate the head of the bed to 30 degrees. We then go for either hypertonic saline or hyperosmolar agent like mannitol. Then some will go for urea, some will go for glycerol, some will add saline diuretics, and if we are faced with subarachnoid hemorrhage, some will go for nimodipine. That is when you are dealing with intracranial pressure medically, using medical agent or medication to deal with that. But majority will just go for neurosurgery, depending on what is picked on the CT scan, and also depending on the availability of the expert, if they have neurosurgeon around. Still on uses, Systemic Mannitol is good for acute tubular necrosis prevention. Okay, if it is given before revascularization during kidney transplantation. Don't worry, I will explain more in a bit. The systemic Mannitol use is, however, contraindicated in severe renal impairment. Okay, you can see, right? This is contradictory to this, right? Not quite. I will explain further in a bit. We have to be cautious in anyone with underlying renal disease. A test dose is necessary before we administer this medication in the face of oliguria, or if you are not sure of the renal status of the patient before us, particularly if there's query renal failure, then we can give a test dose. Other uses of systemic Mannitol will include the treatment of increased intraocular pressure, but you may just refer to ophthalmologists or you try other means before making use of Mannitol for this purpose. In hyphema, when blood accumulates at the anterior chamber, well, you either refer immediately to ophthalmologist if one is close by, or you discuss with your pharmacist to make use of Mannitol for that purpose. In increased intracranial pressure, in cerebral edema, in brain abscess. We also use systemic Mannitol in oliguria or acute renal failure for two reasons. One, for prevention, and also for treatment. But oliguria, I'm not saying in anuria. We don't use it in anuria. Okay? In genito-urinary irrigation, when there is prostatectomy or whatever you are doing in genito-urinary tract, anything transurethral surgery, you can use systemic Mannitol for irrigation. There is a particular form for that purpose. Okay? In kidney transplantation, for both, that is for the donor pre-donation and the recipient pre-receipt, you can use systemic Mannitol. In burns, in bleeding, in shock, in transfusion reaction, in trauma, in amphotericin B to prevent nephrotoxicity. Also useful in the treatment of poisoning when added to saline diuretics, in eliminating barbiturates, bromides, acetylsalicylic acid, or imipramine. It also helps in eliminating uric acid, thereby preventing hyperuricemia after chemotherapy or radiotherapy administration in cancer patients. So in oncology, Mannitol is helpful. In hepatic or gastrointestinal tract medicine, it's helpful in draining ascites, but we will use that with other diuretics. Here you know that potassium sparing, spironolactone will be helpful in draining ascites. So sometimes we add isolate diuretics with spironolactone, and then some will add mannitol, some will add methaxylene. So it depends on what is obtainable in your jurisdiction. Forms. When it comes to solution for irrigation in urological procedures, transurethral procedures, then lisectisol 5% will be helpful, and then it could be cystosol 3% exitors as mannitol solvitor in water. But for intravenous solution only, you can have osmolality and generic form. The reason why it has been bought this way is that we don't give IV solution intramuscularly or subcutaneously. No. The IV solution, that is mannitol, will come under the brand osmolality or the generic form, and it should be given intravenously. Mechanism of action. It produces osmotic diuresis, and that will be done by increasing the osmotic pressure of the glomerular filtrate. Here, tubular absorption of water and electrolyte will be inhibited, so there will be increased urinary output. It may reduce viscosity, but we are not quite sure of the mechanism of how it can reduce the increased intracranial pressure, but it is likely that it reduces the viscosity of the blood. But that is not going to be for a long period, it's going to be transiently. Then there's likelihood of increased blood flow and oxygen transport. And there are some arteries that could be constricted. Water drawn from the brain will be excreted in urine. Of course, if that's not the case, we would then use it. So the water will be drawn from the brain parenchyma and then be excreted via urine. Administration. Like I said earlier, if we are giving intravenous mannitol, systemic mannitol, given intravenously, we don't give it intramuscularly, we don't give it subcutaneously. Even the intravenous solution should be given very slowly. We don't rush it. And we have to warm to dissolve any crystals that could be found there. If we are handling the strength that is 25%, then we should not use polyvinyl chloride bags. Okay? Why that? It may form precipitate. And we don't give it with blood. Why that? If we give it with blood, there may be agglutination, and we don't want that to happen. So a particular given set will be needed for administration of intravenous mannitol. If we are administering systemic mannitol that is greater than 5%, then we go for large veins. Why that? Okay, for the explanation, right? If you have followed this presentation from the onset, I have made reference to the fact that we have to give this systemic agent intravenously and very slowly. Very slowly. In fact, some will specifically write over 1 hour. Apart from the fact that it has to be given very slowly, there's likelihood of extravasation. And when there's extravasation, it's going to be very irritating. It is a vesicant that can cause blisters. And no human being will want that, right? So we are lucky. When there's exacerbation, we have hyaluronidase as the antidote, and we'll give this with tiny needles, the like that we use for sparkling skin testing or insulin. So we'll administer it subcutaneously or intradermal hyaluronidase to avert the exacerbation effect. In the phase of oliguria, I'm not saying anuria, oliguria, we have to give a test dose for 3 to 5 minutes. Also, in transurethral procedures with urologists, irrigation is possible with the brand or the form manufactured for that purpose. So it's going to be urologic irrigating fluid for irrigation during transurethral procedures. Possible contraindications will include hypersensitivity to mannitol, means we are not using mannitol here. Anuria, I will not rush through this. Oliguria is different from anuria. I think now addressing medical personnel, right? But if you are not a medical personnel and you are listening to this, oliguria means you are producing urine, but in smaller amount compared to what is expected of you, okay? But anuria means you are not even producing any urine at all. So in that case, we will not use systemic mannitol. In severe hypovolemia, no. In active intracranial hemorrhage, no. In pulmonary edema or congestion, no. You understand why we don't want to use systemic mannitol under the following conditions in a bit. Drug-drug interaction. To those who are familiar now with my channel, I'll do the same. Please let there be conversation with the pharmacist or your clinical pharmacologist in your jurisdiction. Monitoring. Renal function test. We want to know how well the kidney is doing, okay? Fluid in and out, yes. Serum osmolality, why that? When the osmolality is greater than 20, we will not use systemic mannitol. Adverse reactions, heart failure, chest pain, edema. You could see why we said the other time that we will not use it in pulmonary edema or pulmonary congestion. There may be rebound intracranial pressure. It may lead to dehydration. Of course, diuresis, fluid is not getting out, fluid is being lost. Electrolyte imbalance, because it's being lost, right? There may be dry mouth with nausea and vomiting. There may be thrombophlebitis. In fact, could form blisters when there's extravasation. But we have hyaluronidase as the antidote to handle that. There may be chills, coma, dizziness, seizures, pruritus, rashes, urticaria, right? Hypertension or increased heart rate. May be faced with acid-base imbalance. Hemo concentration, when the water is out, then there will be concentration. Anuria, that is why we don't give it in anuria. There may be hematuria, fever, blood vision, cough, myalgia, or muscle rigidity. Warning, we have to be monitoring for mannitol toxicity. And it is easier to get that done not only with renal function test, fluid in and out, but also with serum osmolar gap. And what we're aiming at is less than 18 to 20. In case of extravasation, we should know that mannitol is a vesicant, meaning it can cause blisters. So we have that as background, and that's why when we are going for a strength that is greater than 5%, then we use light veins. There may be cardiac overload. with pulmonary congestion. So someone is already in heart failure, or someone is already having pulmonary edema, then we think we should use systemic mannitol. No, that won't be helpful. There may be fatal hypersensitivity. That is why under contraindications, hypersensitivity to mannitol means we are not going to use mannitol because it could lead to death. Still under warnings, nephrotoxicity. That is why I've said this will be the fourth time right now that it's helpful in the face of oliguria, but it's detrimental in the face of anuria. So, mannitol on its own could damage the kidney. Fluid loss must be monitored. We should, for now, through skin turgor, dry lips, dry tongue, fluid in and out, whether we're dealing with dehydration already. And of course, we may be battling with hemoconcentration. How about electrolyte loss? So we must assay for the electrolyte, sodium, potassium, and the rest. In renal impairment, we have to be careful. The reason why I have not said don't use it in renal impairment is because it depends on the degree of impairment. In oliguria, we will use it, but we will give a test dose. If we are not sure as per the degree of the renal damage, we will use a test dose. But once we are sure there's anuria, we will never use it. Still on warnings, when we are dealing with pediatric age group, if there's brain injury in them and systemic mannitol is used, within 24 to 48 hours after the injury, there may be intracranial hypertension secondary to generalized cerebral hyperemia. Also, when neurosurgery is performed in pediatric age group and mannitol is used, there may be increased blood flow that can lead to bleeding post-neurosurgery. So, it is fair to say we should expect rebound increased intracranial pressure. The central nervous system complications that may set in can include coma, confusion, or lethargy. I'll go through some few examples here, but please kindly contact the appropriate personnel or specialists when it comes to certain situations when you want to use systemic mannitol. For example, you can contact your pharmacist or clinical pharmacologist. Then when you want to deal with increased intracranial pressure or cerebral edema, you may contact your neurosurgeon or neurologist. And then when you are talking about irrigation or genito-urinary irrigant, contact the urologist. So you can use this trend for increased intracranial pressure or cerebral edema reduction, or this trend for urogenital irrigation. Still on examples, when it comes to kidney transplantation, the two individuals involved, the donor and the recipient, would benefit. The donor would take less at maybe 12.5 grams with IV fluid, while the recipient would take more with about 50 grams. But discuss with your pharmacist, discuss with your urologist. When it comes to increased intraocular pressure reduction, you can go for this trend, but discuss with your pharmacist and your ophthalmologist. Lastly, anything you want to do here, because this is a very helpful medication, but pretty dangerous, please contact your pharmacist or clinical pharmacologist or the expert in that field that's related to the problem you're about to solve. With that, I've come to the end of this very presentation. Remember to share this presentation with your friends Please remember to subscribe to my channel. I appreciate it.